Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. We're recording this podcast on Monday, October the 26th, 2020. Thanks for joining us again today. The COVID-19 pandemic continues with over 8 million cases in the United States and over 230,000 deaths. Experts continue to urge Americans to use safe public health measures, and the CDC last week redefined what it means to have close contact with an infected person. We're going to delve into that a little bit more today. And here with us is Dr. Greg Poland, one of our favorite COVID-19 experts. He is an infectious disease expert and virologist at the Mayo Clinic. Thanks for being here again today, Greg.
My pleasure. We have a lot to talk about.
Sounds like it. There's a lot going on. Unfortunately, this pandemic just keeps going. Greg, I just mentioned a little bit earlier that the CDC had some new guidance about what makes a close contact. Could you tell us a little bit more about that this morning, and why did they change it?
Yeah, they basically redefined a close contact as being within six feet of somebody who is infected for a cumulative 15 minutes over a 24-hour time period. And the reason, that sounds pretty arbitrary, doesn't it? But the reason they did it is they had a prison guard in Vermont, actually, that was known not to be infected, came into contact with a number of the prisoners who had asymptomatic infection. He had, I think, something like 20 contacts over about 17 minutes or less, very quick kind of in and out contact, and yet got infected. And so based on that and the increasing idea of just how infectious this is in terms of airborne transmission, they decided to broaden, if you will, the definition to catch more people. Now, the interesting part of this is if the infected person that you are having contact with is wearing a mask, it still counts as a contact. And the reason for that is the observation that many, many people in America are wearing improper masks, and even when they have a proper mask, are wearing them improperly. And so they elected to not count that as a way of saying you don't need to be tested. Indeed, you still have been exposed and have to get tested.
I admit that I have been seeing more and more people with their mask over their mouth, but not covering their nose. Yeah. And knowing that we test through the nose, it just seems very counterintuitive.
It is. It's not logical at all.
This change by the CDC will lead to more testing, presumably,
yes,
correct?
Yes, that would be the idea, exactly. And the idea is, and maybe we can talk about some of the types of testing, but the idea is to begin catching more asymptomatic infections in order to get a hold of this.
Well, you talked about types of testing, so let's jump right in.
Sure.
I know that there is there are at-home saliva tests being developed, or they're available. How do they work, and do you think that they're useful and helpful?
The test that's kind of out there now is a saliva-based test that is PCR. So it's not detecting antibodies from past infection. It's determining whether you're currently infected. And there's been a little bit of work on this, which makes it interesting. One study published in the New England Journal, I think it was conducted at Harvard, showed that the saliva-based test was as good, or in some cases better, than the nasopharyngeal swab. They then tested this through a separate study group in the jungles of South America, but put them in a cooling chamber, and within 24 hours got them to a testing location, and they were not as good. So what this tells us is this looks to be a good assay. How you collect it is important, and getting it to a good lab is important. All things that are, I suppose, intuitive. But one of the things that was important to my way of thinking when you look at the New England Journal article is that the saliva-based test detected infection earlier and for longer compared to the nasopharyngeal swab. That makes sense in a lot of ways. Seeing it in the nasopharyngeum is an indication of early infection. Getting sputum up from the lungs and the respiratory tract, it makes sense in terms of duration of infection. So while we don't have exact comparisons of sensitivity and specificity across different conditions, it is shaping up that the saliva-based PCR assays are going to be good. What I really like about them is they're less expensive, doesn't require that a healthcare worker be face-to-face with somebody, could be scaled up to the point where they're cheap enough to allow rapid periodic testing, for example. So, kind of stay tuned, but it's looking good.
And as someone who has had 2 tests now with a nasopharyngeal swab, I work in healthcare. I didn't have COVID, but I had reason to be tested.
Yeah.
They're not particularly pleasant. And the
Yeah.
other thing that I've heard about, Greg, is a swab that an individual could perform for themselves, where it's on I suppose the turbinates or the more middle part of the nose than posteriorly. Does that test work, or is it available?
Not as well, and that's a problem with the administered tests or with healthcare workers that are not familiar with doing it. The proper way to do a nasopharyngeal swab is, as you just indicated, it's a thin little swab, but it goes up pretty high. I've had it done myself, fortunately was negative. It's uncomfortable, it's unpleasant. I could kind of tell stuff had been disturbed or irritated for almost a day. So, it's not that it's painful, but I guess I'd put it in the category of unpleasant.
Greg, there has been a question sort of burning on my mind this week that I wanted to talk to you about, because we talked recently about Remdesivir and how there was a study from the World Health Organization showing that Remdesivir doesn't necessarily improve mortality or survival. However, I saw that the FDA approved the use of Remdesivir for COVID-19. So it no longer has to be used under emergency use. It is just available to be used. Can you tell us, it feels like a discrepancy to me and perhaps to some of our listeners as well. Tell us what this all means.
So the most recent trial results to be released are what you just talked about. This is the WHO so-called Solidarity trial. Over 11,000 patients, 400 hospitals across 30 countries. And what they found, at least in the Remdesivir arm, they were studying multiple different therapeutics. They found no difference in mortality, no difference in the need for mechanical ventilation, no difference in the time of hospitalization. They stopped the trial. Now, let's back up. What has happened is in early October, the New England Journal published the NIH trial. This was a much smaller trial, about a little over 1,000 people, and they did find a difference in recovery time. Those that got Remdesivir in about 10 days, those that got placebo on average about 15 days. They also found an increased odds ratio of clinical improvement in people who had gotten Remdesivir. No difference in mortality. So, what did that mean? Does it have to do with the stage of infection at which somebody's infected? Then 2 more studies that had occurred. The Wang study that was published in the Lancet had only 237 subjects. They found a slightly shorter time to clinical improvement, 21 days versus 23 days. Not a huge thing. They stopped it because they were running out of cases, actually, in the area they were doing it. Finally, one other study. These were hospitalized subjects who had moderate to severe COVID, and they found an increased odds ratio of clinical improvement, but not a mortality benefit. So we're left with this small handful of studies conducted under different conditions in patients who are at different levels of disease and slightly different characteristics. I will say one thing against the Solidarity trial is that there was a moderate amount of data missing from some of those participants. So we're kind of, my view of this is Remdesivir does not appear to have any ill effects. So that's a good thing. And at least in several of the trials, it has reduced the time to clinical improvement. It does not appear that there's a mortality benefit. I think we're kind of left in a quandary of saying, in an environment of a pandemic where we have precious little else, this might be a small incremental benefit, but not a game changer.
Multiple of the therapies that are available or being used currently for COVID are available to hospitalized patients. Does
Yeah.
this mean that Remdesivir will be available to patients who are diagnosed but don't require hospitalization?
Yeah, good question, actually. And there's not been a lot of discussion about that. Part of the problem is that it requires IV administration at this point. So some people say 5 days, some people say 10 days. One study showed no benefit to 10 days. So you're talking about at least 5 days of IV administration once a day. So that's one issue. The other issue, and my sympathies lie with the direction you're going, is that in general, we know that viral infections are best treated early on, not once they're already starting to produce pathology like pneumonia. But that study hasn't been done yet and needs to be done.
Well, Greg, the FDA has been busy. They also held a panel to stress safety, diversity, and efficacy for COVID-19 vaccines. And I'm wondering what prompted this, and were there any outcomes that we
Yeah.
should know about?
And I attended the meeting virtually, of course, as did everybody. And I previously served on that committee, so I'm very familiar with how the committee runs and what they do. And what this meeting was I think, number one, an attempt to socialize with the committee members and the public what was going to be discussed and what were the primary issues. And very typically, FDA presents what data is available and then has a list of questions that they ask the committee, as they did this time. One of the things I think they're doing is signaling, we had released enhanced guidance. We're going to make this a fully transparent process. So bravo to them for doing this. And we're not going to let politics, public pressure, anything like that dictate the process. This is going to be an evidence-based science process. So I was very, very glad with how the meeting was conducted and how they sort of framed it. The thing that came out of this, which I think is very, very appropriate, I've talked about it, I published on it, is this idea of EUA versus another mechanism. And one of those mechanisms that's available, we talked about it in an early episode, actually, of this series, is so-called expanded use or compassionate use of a vaccine. I like this route. And the reason being is expanded use keeps the frame or the idea of a clinical trial. So let me just briefly recapitulate here. An emergency use authorization would allow, in a designated group of people, the use of the vaccine with no particular data collection. There's a number of implications of that. The people currently in trials would say, why should I continue in the trial? I might be in the placebo group. I'm going to go get the vaccine. Now our studies become worthless. You can never go back into a blinded, study. It's done. So we will not have long-term data. We won't know, is the vaccine safe? Is it effective? Is it durable? Did it decrease the risk of infection, illness, or complications? So a major compromise of what we're trying to learn by these vaccines. So the idea then is that you have two other options, this expanded use and a fully licensed vaccine. Expanded use would allow the use of the vaccine in a high-risk group, but, and here's the difference, they have to give informed consent and you have to collect clinical data, such as safety and efficacy data. So it would not compromise the ongoing trials because you would not be admitted, if you will, into an expanded use type study. It would provide early access to the vaccine in those at highest risk, but it would allow the continued simultaneous evaluation of the vaccines that are currently being studied. So Dr. Gruber at FDA raised this with the committee. I think the committee saw the wisdom of that right away. There was no pushback on that. And I really like that idea. In part, it does push out the release of vaccines, but the trade-off is better safety data and longer time period to look for safety and efficacy.
Naturally, all of us are kind of hanging on the edge of our seats waiting to hear more about vaccines. And so we look forward to hearing more from you as you learn more about those topics. Some time ago, I had discussed previously with a pediatric intensivist about multisystem inflammatory syndrome in children related to COVID-19. And now it seems there are some cases discovered in adults. And I'm wondering why and what do you make of this?
I must say, this is a bit of an enigma medically as to what's going on. It was observed, as you mentioned, and we've talked about on this series, in children initially. And it's called MIS-C for children or A for adults. And MIS is just multisystem inflammatory syndrome. It's been reported in about 16 adults worldwide. It has certainly occurred more often than that. When you look back, many people in some of the hot spots, for example, New York, will say, we had patients that came in late with multi-organ failure, but without respiratory symptoms. That is typical of what we now know about this syndrome. The typical case, as we understand it right now, is somebody who comes in with rapidly deteriorating multi-organ failure, very little or no respiratory symptoms. The reason for that is they've been infected in the past 2 to 6 weeks, but are not infected now. They have antibodies, but negative swabs. So it appears to be something related to the ongoing immune response or the antibodies that were created. The other thing is it's happened primarily in younger people, 20 to 50, 60 years old, not in the older group. And with one exception, and this may be chance, it may be related to the increase in infection, only one case has not occurred in a minority population. So they by far have occurred in minority populations. The issue is what's causing this and what do we do about it? It's organ support, it's fluid support, it's dexamethasone to suppress the immune response. Tocil's being used as an IL-6 inhibitor, but we're kind of shooting blindly, to tell you the truth, because we don't yet know the causative aspect of the pathophysiology that we're seeing. So this is another example of not taking this virus lightly. Even after infection and what appears to be recovery, people, rarely it looks like, but people can enter into this multisystem inflammatory syndrome weeks later. And that's a very unusual thing for a viral infection like this. So we're learning every week about the incredible harm that this virus is capable of doing. And again, I guess it leads to a plea for our listeners to please take this seriously. We are now hearing, by the way, of healthcare providers in some of the southern states that are not taking proper precautions, not wearing masks when they're seeing patients. And this, of course, is driving what we're seeing in the country. As you mentioned, Friday we had almost 83,000 new cases. This is very bad news in terms of controlling this infection. And yet, we know that distancing and mask wearing is very effective if we can get people to do it.
I was thinking, Greg, about what you said about diagnosing this multisystem inflammatory syndrome and how difficult that might be. The anesthesiologist in me says, wow, if the patient doesn't test positive for COVID, that could be very confusing because it could look like a number of other disorders, I would imagine.
There's sort of a typical clinical picture that is not by itself diagnostic. So it's organ failure, except for the lungs. It's very high levels of inflammatory markers, the absence of current infection, but the presence of antibodies indicating recent infection. The other interesting thing is we have typically treated these very severe cases with convalescent serum. In this case, where infection has passed, but the immune response appears to be aberrant, adding convalescent serum may actually worsen it. So we want to be sure that we're using convalescent serum, or plasma, I should say, in the early stages, but not in the later recovery stages.
Any last words of wisdom for us today?
I just think we're all getting tired of COVID, and there's kind of COVID fatigue, and we're tempted to cut corners. And I certainly see it. I sometimes feel it for myself. And I think we just need to be vigilant. If you care about your health and those around you, wear a mask, maintain physical distancing, wash your hands, get your flu vaccine. And those are the things that we can do that are helpful.
Thanks so much to Dr. Greg Poland for being with us again today and giving us our COVID-19 updates. I hope that you've learned something today. I know that I have, and we wish you just a wonderful day today.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening, and be well.